Okay, I think we'll begin. So once again, good evening, everyone, and welcome to the Community Stakeholder COVID-19 Vaccine Information Session tonight. My name is Fazia Beg, and I'm the lead for the Community Engagement Working Group for the Vaccine Distribution Task Force. The working group, some of whom you'll have a chance to meet today, coordinated this event for you as an opportunity to provide some information on the vaccine and the rollout in the Waterloo region, and what you as community leaders and organizations can do to support that rollout. You will hear from a panel of speakers, followed by a Q&A session. We're anticipating that this whole session will last for just over an hour and a half. And to get the session started, I'm very happy to turn it over to Chair Redmond with some opening remarks.
Thank you so much, Fazia, and thank you to everyone for joining us this evening. This incredible turnout is truly indicative of the importance of this work to our community. I wish to begin our event by acknowledging that the land on which we gather virtually today is the traditional territory of the Haudenosaunee, Anishinaabe, and Neutral people. We acknowledge the enduring presence of the Indigenous people with whom we share this land today, their achievements and their contributions to our community. A large portion of the Waterloo region falls within the Haldimand Tract, the land 6 miles on either side of the Grand River. It was granted to the Haudenosaunee after the American Revolution as compensation for supporting the British in the war. Of the 950,000 acres originally granted, less than 5% remains as part of the Six Nations of the Grand River Reserve today. I offer this acknowledgement as a small act of reconciliation between non-Indigenous and Indigenous people today. I'm pleased to be joined by Elder Gerard Sagasny. I knew I would screw up your name, Gerard, I apologize. Today, who will help us set intentions for this evening. Gerard is from the Curve Lake First Nation with family connections to Serpent River. He has been assisting with healing work for over 20 years. He is a Midewiwin Lodge member and has worked with many teachers throughout his travels.
Naha buju kinawi aik mandayani shkabevis. You know, as we sit around and around a sacred fire of spirit, and we always talk about neighboring, that healing work that they've been talking about for over 20 years. It's actually been a bit longer. The healing work where that comes from is actually medicine work with plants and nature and fish and bear, all those things that relate to that. But a lot of it is spirit. A lot of it is faith-based. A lot of it is hope-based. And a lot of it is love-based. And when you really think about our ancestors on any walk of life in those four directions, from the peoples of Buddha and from the peoples of Jishua, which is Jesus, and from the peoples of Mohammed, and from the peoples of Wanabuju, that everybody has a higher power of faith into the unknowns, even those ones that have no belief. When you think about vaccines, and you think about the rollouts, I've just recently got my first vaccine. I could have got a vaccine last night, but I probably wouldn't have been here today. I would have been grouchy. But it didn't make me grouchy. And why I say that in a way is that historically, there's always been epidemics and pandemics of globally from the beginning of whenever the infinity of humans started. And when you look at realizations or the modern eras of polio back in the 1950s and 60s, and how little polio there is in the world of today. And then you look at SARS of 2003. Now people make it really think that the vaccine was just begin to create itself in July or August, but it's been in creation. It's been sitting, it's been looked at, it's been studied. And you're always going to have nayers and you're always going to have yayers in anything that you have to decide. The vaccine itself is a personal choice. But the personal choice doesn't make it reality until the pillow beside you is empty. That's the realization that, wow, I should have masked up. Wow, I should have vaccinated up. Those are the things that I don't want my grandkids to echo. I'm a traditional health practitioner, which is almost the same length as a physician in Western medicine, I guess mainstream medicine. And where it is that I work in the Sioux tribe of Michigan, and I work alongside medical professionals in all walks of life, from neurologists to pediatricians, and some specialness within caring for human beings on health recovery. So para we had to go and shnambe ya kada minido gamin go ya sono gano gasono on, is that the spirit will honor you or honor us in the makings of what I call a medicine camp, wherever the vaccination is. That it's a nest of opportunity. When we begin to warm the fire and warmth the fire with the ones wanting vaccination, then that's where you begin to create what the vaccination was for, to be with. So when you think about that song, it goes like this. It goes, Bojo Bojo Arishna, Bojo Bojo Arishna, Bojo Bojo Merito, Bojo Bojo Merito, Arishna ya 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 ya. Bojo 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 Arishna ya Buddha ya 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 ya. Bojo Bojo Arishna, Bojo 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 Arishna ya 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 ya. Bojo Bojo Arishna, Bojo Bojo Arishna, Bojo Bojo Mohammed, Bojo Bojo Mohammed, Arishna ya 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 ya. Bojo Bojo Anaya, Bojo Bojo Arishna, Bojo Bojo Anaya, Wana Bojo Arishna, Wana Bojo Gaya. It's like acknowledging those four helpers or those four uncles. And whenever we open the doors to the unknown, we come with caution, but we leave filled with hope. Where I work, we've ran 3 vaccination clinics, 5,100 people, a small tribe in Bow Outing territory, the Sioux tribe of Sault Ste. Marie. And the last one last week, and we did 1,700 in two and a half days. That's medicine. When you see middle-aged people visiting with the elders that they hadn't seen for months, that's medicine. When you see community and different, different brothers and sisters of the world visiting, that's what we're put on earth for, is to live in peace and to live in harmony and to live with respect and to live with truth. So when we get to circle with nests like this one in Waterloo region or Kitchener region or Guelph region or Cambridge region, all of us out there are medicine helpers. There's no other way of defining them. And when you put yourself aside for the helping of others, that's what you genuinely say, define that as a natural helper, a natural want. And to everybody out there in the audience, really think about that. Really think about the natural way of helping. Tammy will always hear me say that we can never go back to the golden days, but we can return to the olden ways of love, faith, hope, and respect. With that being said, I just want to say something in the language to each and every one of us. And what it does is it pays acknowledgement to Shkikamekwe, to the water where all earth is. And to be mindful of this word, Mishkiki Nawal, which is the definition of natural words of the vaccine, the medicine juice or the medicine water. Mishkiki Nawabo. Bonjour.
Thank you, Gerard. Thank you for your good words. Thank you for your important thoughts.
Wasajin Ago, Mabage Wasawabang, Mabage Nungo. Chinui Aik, Monagain Anibui Aik, Gana Mishkundad, the Mishkuyaya Yabik. Miigwech.
Thank you, Gerard, for your good words and for your important thoughts, because they bring meaning and they remind all of us why we're here today. This work is truly about community. Recently, as chair of Waterloo Region, I made delegation to the Minister of Finance on the upcoming provincial budget. And I told Minister Bethan Falvey that one of the defining characteristics of Waterloo Region is that we collaborate and we cooperate. As a matter of fact, those things are in our DNA. And I believe the statement to be true. But I also acknowledge that it has not always included everyone in our community. Indigenous, Black, and other racialized community members have not been treated equitably. That is why in June, Waterloo Regional Council made a unanimous commitment to action on systemic racism. It's why our 2021 budget, we invested $20 million in affordable housing And it's why we're investing $15 million to take action against systemic racism over the next 2 years. We know our efforts will not be a perfect response, and we know that they will not speak to everyone, but we know it will not be fast enough, but we are committed. These investments through the budget are a demonstration of that commitment, and tonight's information session is a demonstration of this commitment. This information session was informed through the participation of members from the Indigenous, Black, and racialized communities. They worked with staff to identify what questions and what concerns should be addressed, and I'm looking forward to the information and the discussion. I will now turn it back over to Fazia, who will introduce the organizers of tonight's session.
Thank you, Chair Redmond. And again, thank you, Elder Gerard, for sharing those wise words and really grounding us as we move forward in the session tonight and move forward on in life as well. So thank you for that. So I will now introduce the Community Engagement Working Group. I do want to share a little bit about what the working group is involved with as well. So I'm just going to get some help with our PowerPoint slide. Perfect. So here are the members of the Community Engagement Working Group of the Vaccine Distribution Task Force. I put the members in alpha order, I hope, so forgive me if someone is out of place, but the members include Adele Parkinson from Public Health, Chris McAvoy from Housing at the region, Cynthia Martin, our Indigenous Initiatives Advisor, Dave Remy from Southwest Ontario Aboriginal Health Access Centre, Deb Ruprecht, Advocacy Lead Indigenous Health and Wellness from Waterloo Wellington, Eric Boynton, Sergeant for the Equity and Inclusion Diversity Unit, Ismail Mohammed, who is a leader for the Somali community, Laurie Fiosi, Manager at Region of Waterloo, Meredith Radlin, who is a member of our Anti-Racism Advisory Working Group, and Tammy Webster, who is also a member of our Anti-Racism Advisory Working Group. And so just to give you a little bit of context, this working group, the main goal really is to engage community leaders and stakeholders to inform, plan, and design vaccine communications to provide accurate information about the vaccine, build trust in the vaccine and vaccine safety, and to inform vaccine distribution plans to ensure equitable delivery. This includes understanding the causes of vaccine questioning or vaccine hesitancy, providing vaccine information in culturally and community appropriate ways, and understanding barriers and challenges that are faced by some in order to access vaccinations. So I'm going to ask that we take off the PowerPoint, and that now I'll turn it over to Meredith to say a few words.
Thank you, Fazia. I was invited to participate in this group as a member of the Anti-Racist Working Group, but also as a member of the Black community. As Chairman Redmond mentioned, it has not been the practice to include marginalized and racialized communities in many of the major initiatives done by the region. So this community engagement group is an attempt to ensure that voices that are usually excluded from the discussion are invited to be heard. So I am happy to be representing the Black community, which is very diverse, many cultures, many languages. And my role here really is to communicate, to work with the region to ensure that the messages that need to be heard about the vaccine rollout are communicated to the communities. But more importantly, to ensure that the voices of the Black community are included in the conversation and decision-making of the rollout. Equitable delivery of the vaccine requires an anti-racist framework, and an anti-racist framework requires that the voices of racialized people be listened to, be heard, and be invited into the conversation.
Thank you, Meredith. I think, Tammy, if you want to go next.
Gagana. My name is Tammy Webster, and I was invited to this working group on behalf of the Anti-Racism Advisory Working Group as well, with Maedith. I'm also the Indigenous Education Lead at Waterloo Catholic District School Board, and I'm bringing the First Nations Métis Inuit voice to the table. And echoing a lot of Maedith's sentiments on this, it's imperative that these voices who have a long withstanding history around medical practices actually can come to the table and have our voices heard. And how I view this is really a turning point in terms of a relationship that's being established. We've been invited to come to this table to help engage, to help communicate, and to also help educate so that we can move forward from some of the history and some of the traumas of that and do it in a different light. This is a great time for us to really rally together, like Gerard had said, this nest of helpers. And it's not on one of us, it's not on individuals, it's really a community driven. And it's I've enjoyed being invited to this table to help that partnership and that relationship.
Thank you, Tammy. And Chris.
Thanks, Fazia. Hi, everyone. So my name is Chris McAvoy, and I work in housing services at the region of Waterloo, specifically supporting the portfolios of street outreach, emergency shelter, and supportive housing. And so I'm here representing the housing stability system, which supports individuals in our community who are currently experiencing homelessness, living rough, or unsheltered. And so the goal of the Community Engagement Working Group is to assist in the development of a community engagement plan for vaccine distribution in priority populations, and to engage and identify community leaders, community organizations, and social influencers to promote and build trust in the vaccination in priority populations. And that's why we're here today, to share information with you, to hear what questions you have, and hear from you on how we can develop a robust community engagement plan for vaccine distribution. So the how might we, in my mind, is how might we develop an implementation plan that meets people where they're at and recognizes and responds to their unique assets as well as their needs.
Thank you, Chris. I have to say I've enjoyed working with every member of the Community Engagement Working Group. So this has been a really great opportunity as well for me. So I'd like to start off with our presentations for this evening. First, we have Dr. Kelly Grindrod, and I'm going to ask if we can go back to our slides. Just one over from this one, please. Perfect. So Dr. Kelly Grindrod is is a professor at School of Pharmacy at the University of Waterloo. And I'm just going to turn it over to her to lead you through her presentation.
Thanks so much, Fazia. Okay, so next slide. So I'm going to take you through a slide deck. This was produced in collaboration with several physicians, pharmacists, nurses around Canada under this initiative called 19 to 0. Next slide, please. So there's three main things that we're going to go through. And I know there's a diverse group in terms of skill level, education, awareness of the vaccine, comfort with the vaccine. There's going to be people on the call, as we've already heard, who have already been vaccinated, and people who might be a ways out yet from getting a vaccine, which also might mean you don't quite know which type of vaccine you're going to get. So the three main objectives are pretty overarching then. The first is to understand how mRNA vaccines work. The second is to review the COVID-19 vaccines approved in Canada and the other vaccines coming, and to review the contraindications and precautions of these vaccines and their side effects. Next slide, please. So this is part of a series of graphics that we've been creating at the University of Waterloo. And if you have organizations that you want to work with us on adapting these, please reach out and we're happy to help you with that. But the mRNA vaccine is like a most wanted poster that tells your body how to recognize COVID-19. It can't and won't change your DNA. This is probably one of, if not the most common question that we get. Can this change my DNA? The mRNA vaccine does not change your DNA. Next slide. So how does it work then? So if you start on the left-hand side, mRNA vaccine is injected into your body. And as I said, it can't change your DNA. If you go to number 2, what happens is your cells read the mRNA instructions and they start building the same kind of spike proteins that COVID-19 had. Those spikes, though, are harmless. And the thing to know about mRNA is it's extremely unstable. So a lot of the research on mRNA vaccines in the last 10 years largely focused on how to get it stable enough to actually be effective for people. That's why we're freezing it at -70. This is why we can't shake the vials. It's really hard to get it out to certain areas. You know, as long as we have the Pfizer mRNA vaccine, for example, that really restricts where we can reach people because it's so fragile. So you can imagine once you actually have the vaccination and it's injected into your body and it does its work, it actually dissolves or disintegrates really quickly. For number 3, your immune system then sees the spike protein and it starts building a defense. And so you've got your cells here, you can see they sound the alarm and they launch an attack. This is the point at which you might feel some fatigue, aches, or a fever, but it's actually your immune system learning about how to fight COVID. So number 4, now your body can recognize the COVID-19 spike protein and fight COVID-19 effectively. So once you've gone through this process, and you'll note, you're not injected with the virus, you're injected with information on how to build the virus. Another idea here, another analogy I found useful is likening it to a Post-it note, where it's almost like, you know how you write yourself little notes around the house that you leave maybe on your computer or on a cupboard, you might leave them for your spouse or a child with some instructions on something you need them to do. They come along, they find the Post-it note, they commit to memory that they have to do this thing, and they throw the Post-it note out. That's really very much how an mRNA vaccine works. You learn something, you remember it. It doesn't actually change you. It just gives you a bit of knowledge or a memory. Very much the same idea. Next slide, please. And unfortunately, I could not get this to be a clear image no matter how many ways I tried it. The point here, though, is that this is a graphic on vaccine development, but this is actually part of a suite of tools from Health Canada that were released a little while ago. You can actually use these. They've got these on the Public Health Agency of Canada and Health Canada website. And basically what it's showing you is start to finish how the vaccine production happens. And so you've got the scientists working on the left-hand side at the top there. And the thing to know about the mRNA vaccines is the research actually started for this in the late 1970s. A lot of the work that's been done in the last 10 years or so is actually focused on vaccines like vaccines for Ebola, Zika, vaccines for cancer, vaccines for HIV. So this is a technology that was already being looked at quite well by the time COVID came around. So it was ready for this pandemic. Then what happens is once you've got a technology that needs to get ready to go, you've got to build it, and then you put it through trials. So the first phase, phase number 1, is where you're trying to figure out, you know, what's the dose we're going to give. So we're kind of going through this to a certain extent with children right now. We've got the adult vaccines, but we don't know the right dose for kids. So you have to kind of do this work. What is the right dose? What is the appropriate amount? And that's just with a handful of people. It's less than 100 people. Then you head into the phase 2 trials where you're looking more, does it actually work? Are there any big, you know, alerts here about safety? And then there's phase 3, which is when you're actually going out to tens of thousands of people. And as you'll see with these mRNA vaccines, you know, it was 30,000, 40,000 people in a trial. So we'll often hear people say things like, I don't want to be a guinea pig. But, you know, one of the things to keep in mind is the people who actually signed up and consented to these phases of these trials were the ones that were actually experimented on. So in this case, what's interesting is vaccine research is slow, unfortunately. It takes years, but it's actually because of inefficiencies between each of these phases. You have to do that first little bit in those first 2 blocks, and then wait a while to get money, and then do the next, you know, phase 1, and then wait a while to get money, and then phase 2, and so on and so forth. What happened in the pandemic is all around the world, they invested incredible sums of money, organized, published protocols, extremely transparent, worked with regulators, and they actually streamlined this entire process that normally takes years, if not a decade, and actually were able to condense it down to less than a year. So we often hear, you know, this vaccine research was too fast, I feel uncomfortable, but in actual fact, this is how it should work. This was an ideal state. It wasn't too fast, it was actually an example of what research could be if we ran it like this normally. Along the bottom, then what you see is all the other work that happens. So you've got to get it approved, you know, provinces have got to buy it, we've got to move it out, and that's the phase we're at now. And then the last bit there is we track to see what happens. We track to see side effects, things that were unexpected, so on and so forth. Next slide. So there's 2 vaccines approved for emergency authorization in Canada right now. They're both mRNA based. So there's the Pfizer-BioNTech vaccine. That's the one that we see a lot of in our region right now, and Moderna. They're both 2-dose schedules, which mean we need to touch each person 2 times to get them immune using these vaccines. The Pfizer one is 0 and 21 days. The Moderna is 0 and 28 days, and you've got a bit of leeway. The trials also had a bit of leeway baked into them too. Pfizer was 16 and up, and Moderna was 18 and up for the trials. And that's why you see this being used in adults right now and not children. So a while back, we heard that the studies for 12 and older were underway. And now we're starting to hear that the trials as young as 6 and older are underway as well. So that gives us hope that we'll have vaccines for children in the coming months as well. Next slide. Okay, so how effective are they? And this is an interesting thing. So Pfizer is 95% effective to protect you from having the disease, and Moderna is 94.1. And this was similar when they did all the subgroup analysis. This is similar race, ethnicity, age. And this is the moment where I was talking to an infectious disease doctor a little while back, and she said this was the point at which I started to cry. This was her comment. For a lot of us, this so far exceeded our expectations of what a vaccine could look like in this pandemic. This was huge. And it wasn't just that 94 or 95% efficacy was huge. It was the fact that it held up across ages. Even in seniors, you were seeing these effects, which is incredible. And it's basically the best we could have hoped for in the situation. Next slide. So what about contraindications and precautions for mRNA vaccines? So you would not be offered one of these vaccines, or you should not take one of these vaccines if you have a previously confirmed allergy to a vaccine dose or a vaccine component. So that means, for example, you have the first dose of the COVID vaccine and you have an allergy, like an anaphylactic reaction, you would not be offered the second dose. That's an example of that. Another thing is if you already know that you have an anaphylactic allergy or a serious allergy to, or just to say an allergy, to one of the ingredients in the vaccine, then you wouldn't be getting the vaccine. But these vaccines actually have very simple ingredients in them. So there isn't much in there. So most people actually can receive this vaccine. So the other one would be symptoms of confirmed or suspected SARS-CoV-2 infection. So if you have symptoms or you're suspected of having COVID, we would wait until you're recovered. There's some question too about waiting a few months after you've had an infection. And there's some debate. A lot of it has to do with vaccine scarcity, even if there isn't enough supply and you have some immunity. But this is a big debate that people are having. Another is acutely ill individuals as a precautionary measure. That has to do with making sure that when you get the vaccine, you're healthy so you can have a full immune response. So it's actually about efficacy. And individuals who have received another vaccine in the past 14 days. So the common one here would be the Shingrix vaccine or a pneumonia vaccine, for example. And again, it's just about making sure or ensuring that you get the most efficacy that you can. Next slide. So what about allergies? Let's go back to those a little bit. Allergy rates do seem to be higher with the mRNA vaccines, but in all cases, outcomes have been good. So what we do is we recommend that people who have a history of anaphylaxis to other allergens should wait 30 minutes post-vaccine. So most people wait 15 minutes. If you have a history of this, you may be asked to wait 30 minutes just to be sure. And 90% of these anaphylactic events have happened within that 30-minute period. The other thing to note here is that so with a flu shot, for example, rates of anaphylaxis might be 1 in a million. With mRNA vaccines, it's about 10 in a million. So it's still not a common encounter. We wouldn't expect it, but every vaccine center is trained to deal with anaphylaxis like this. Next slide. So as your immune system learns from the COVID vaccine, you may have some fatigue, headache, achy muscles, chills, and a low fever, feeling slightly bad for a short time as you build immunity for a long time. So again, these side effects with this too are a sign that it could be, it's working, and these aren't necessarily a bad thing. These can be a good thing. Next slide. So what should I remember from the side effects of this vaccine? So the number one thing for you to know is 8 in 10 people complain of a sore arm. After you get a vaccine, your arm's probably gonna hurt. So the vast majority of people are going to have a sore arm, but only 1 in 100 actually call that soreness severe. So the big one that we hear people say it's like is the Shingrix vaccine. They often say after the Shingrix vaccine, oh, it hurts a little bit. Same thing with this one. 5 in 10 people complain of fatigue and headache, but only 1 in 10 need Advil or Tylenol. And I want to point out there too, there were actually pretty high numbers of fatigue and headache in the placebo group. And when I saw that, one of my first thoughts is that's just kind of what it feels like to live through a pandemic. So, there's kind of what you feel like at a baseline, and then you may have some additional effects after you have the vaccine. And some reaction to the vaccine is expected, but the majority are mild and easily manageable at home. You're most likely to have these effects 2 to 3 days after you get the vaccine. They're generally short-lived, They're more common after the second dose, and they're more common in younger people. Next slide, please. So these numbers, they haven't been updated since January. I was looking at them right before this presentation, and we're well over 1 million doses administered now. I think we're at 1.3 million doses. But one of the things that we hear from groups is that when they're the priority groups, it can feel sometimes like being guinea pigs. It can feel sometimes like they are being pushed to the front in a new vaccine we know very little about. But one of the things that's happening now is millions of people around the world have been given these doses. Millions of people around the world have been given these vaccines, and things are going really, really well. And so people now in populations who are getting them are actually high priority groups as opposed to experimental groups. And I think that can sometimes be important for people. It can be anyone, you know, who might feel like it's a little bit too early. You can rest assured that millions of people have been given these vaccines at this point. Next slide. So here's an example of a Q&A that we created, and these are the main questions that we've gotten. So I've already talked about the vaccines being developed so fast and because it was such an efficient process. We've also talked about how mRNA vaccines don't change your DNA. And the other question we get is, are the ingredients in mRNA vaccines safe? So yes, they're safe. They're often called preservative-free vaccines. How we actually preserve them is we freeze them at crazy cold temperatures, which it turns out is really complicated for actually administering to large populations, but works really well for actually getting that mRNA to be stable. There's other things in there. So you've got your unstable mRNA. So how we stabilize it is we surround it by a fatty layer, a fatty nanoparticle layer. And with polyethylene glycol is one of the ingredients in that. Very common ingredient. We see it in a lot of things. So that helps it keep its structure. And then some salt, sugar, and water. There are no blood products, no pork products, no fetal tissues, nothing like that. They're actually very simple vaccines in terms of ingredients. And then the last big question we get is, but we still need long-term data. And this is absolutely a valid point. We actually do need long-term data. Now, we don't need, it's not safety data we're waiting for though, it's efficacy data. So in vaccine trials, side effects we're looking for are in the first 6 weeks after vaccination. The first few days, you're looking for the side effects we've already talked about, sore arms, fatigue, headache, that's normal. About 6 weeks out, up to 6 weeks out, we might be looking for things like Guillain-Barré or very specific neurological things. Now, to be clear, viruses often cause those things as well. So we know with vaccines in the past, serious side effects like that are often not just caused by the vaccine, they're actually caused often in greater proportions by the illness, if you actually catch the illness. So we watch for 6 weeks in the trials, but what we're actually waiting for now long-term is to know how long do these vaccines last? Do you need a booster? When do you need a booster? And the last big question we're really waiting for information on is, once you're vaccinated, it might protect you from feeling sick from COVID, but does it protect you from being contagious if you actually do come in contact? Next slide, please. This is another one that comes up occasionally. I don't hear it as much anymore, but I was hearing it last few weeks. Will vaccines cause infertility? In short, no, there's no evidence to support this claim. Next slide. So just a few brief words on the next one. So Astrovenica is the next one likely to be approved in Canada. It's a viral vector vaccine. It uses a chimpanzee cold virus to actually bury that spike protein information to show to your body. The thing about chimpanzee cold viruses is they don't make humans sick, and we haven't been exposed to them, so we don't have antibodies against them. So it actually works pretty well for giving us, our bodies, almost like a backpack. It brings with it a backpack, your mRNA or your DNA information about the spike protein, teaches your body how to make a spike. These are fairly effective. So in the grand scheme of things, it's a fairly effective vaccine. They're not as wonderfully effective as you would see with the mRNA vaccines, for example, because like I said, those are just so overwhelming. So one of the big questions here with the AstraZeneca vaccine is, can we give the AstraZeneca vaccine now and maybe an mRNA booster later, maybe in the fall, to boost that efficacy? So waiting to see. That's also a 2-dose vaccine. It's also like flu vaccines in that it's fridge temperature stored. So it's a lot easier to get out to pharmacies and doctors' offices. So that actually increases our reach by a lot. Johnson & Johnson is a very similar type of vaccine, but it's 1 dose, not 2. So that's promising. And the Novavax vaccine, we recently heard information on because it's manufactured in Montreal. So it's a different kind of vaccine, but there's some hope for that one as well. It looks to be pretty effective. Next slide, please. So when we're considering whether, from talking within our communities and talking to people about whether or not to get the vaccine, on the left-hand side, there's a lot of focus on, well, does it work? And I'm not at risk, so should I really get it? Or should I wait? If I'm offered the Astrovenica, should I wait until I get the Moderna or the Pfizer? And vaccine safety and rare side effects. But in actual fact, one of the things we need to talk a lot about is vaccines work and they're safe. We're all at risk of COVID right now, and this is really the way out. Next slide. And what you see here is just our general population's willingness. So you can see in the summer, before this was really a real idea that we knew what vaccines would be used, less than half of Canadians were willing to get the vaccine. But as time went on into the summer, into the fall and into the winter, and now in January, you can see those numbers are going up quite a bit. So the more comfortable we get, Canadians in general are more willing to get the vaccine. Next slide. So if you did get the vaccine, like Gerard at the beginning, be proud and make it public. Let people know. People are more likely to get a vaccine if their healthcare provider got it. We're also hearing in workplaces when their colleagues got it, healthcare providers, when their patients start getting it, that can impact for them their comfort with it. So be open about this. Let people know your experiences. Positive messaging about this vaccine is actually pretty effective. And I think that's the last slide.
Thank you, Kelly. That was very informative. I thought I'd known a lot about vaccines already, but hearing you speak and go through those slides, I picked up a few more tips and information there. So thanks for sharing that. I'd like to welcome our next set of speakers is Dr. Wong, Medical Officer of Health at the Region of Waterloo, and Dr. Ball, who's our Primary Care Physician Lead for the Vaccine Distribution Task Force. So I'm going to turn it over to Dr. Ball and Dr. Wong.
Thanks, Fazia. Thanks, everyone, for the opportunity to be here. If I could go to the next slide, please. And actually, we'll go right to the next slide. Okay, so Dr. Ball and myself are going to talk about three things. One, the rollout of the vaccine, going over the provincial prioritization and phases of the vaccine rollout. Two, providing an update on how we've done so far in Waterloo Region in terms of vaccine distribution. Sorry, that was two. And three, our plan, the task force's plan for the ramp up of immunizations or vaccinations in Waterloo Region in the coming months. So if we go to the next slide. Thanks. So before I go into information about the rollout of the vaccine and its different phases, I wanted to start with a quick overview of the roles of the federal, provincial, and local governments. With respect to the federal government, they procure the supply of vaccines for Canada, they approve vaccines for use in Canada, and they distribute vaccines to the provinces and territories. The provincial government receives vaccine from the federal government, prioritizes the rollout, including who will get the vaccine when, and distributes vaccines to local areas, including local hospitals and public health units. And finally, in Waterloo Region, we receive vaccines from the provincial government, and we distribute and administer the vaccine based on the province's prioritization framework. If you go to the next slide, please. So I know this is a busy slide, but I'm just going to describe at a high level what this is about. So the Ontario government is rolling out a 3-phase distribution plan to administer COVID-19 vaccines as they become available. Rollout started with the highest risk groups. And as supply increases, we'll include more and more population groups according to the province's prioritization framework. And supply is expected to grow exponentially over time. So the province has developed this placemat, which you see here, to help us visualize at a high level the 3 phases of the rollout, and at a high level the prioritization of the various groups. So this is the latest version of Ontario's placemat from January 11th, 2021. They will be coming out with a new version shortly, which you'll be able to find on their website, or you can find it through a link from our website when it's available, because they have made some recent updates to the prioritization framework, which Dr. Ball will touch upon a little later, but it's not available yet, so this is the old framework. And overall, you can find the specifics of the framework on their website, but overall, it focuses first on the most vulnerable populations who are at greatest risk of COVID-19 and those who care for them. This is phase 1, and phase 1 continues through to April. Then, as more vaccine becomes available through the months of April to August, we expect a significant increase in supply then. Other groups considered higher priority will have vaccine made available to them as well. And that's termed, and this period is termed phase 2. And then beginning in August and continuing onwards, it is anticipated that there will be a continual and ample supply of vaccines at that point, such that anyone who has not yet received a vaccine and would like one will be able to receive one. So this is phase 3. So the different phases, even though they seem to have start and end dates, which they broadly do not actually have hard start and end dates. Vaccination rollout phases will be continuous and overlapping. For example, phase 2 vaccinations are likely to begin while phase 1 is still ongoing, as long as we have sufficient supply. So in short, the key message from this visualization, this placemat, is there is a prioritization that is set by the province of various sectors and population groups through 3 phases. So if we go to the next slide, please. So this is the latest version of our local placemat, which has our local numbers in it. And again, I know it's not possible to really see the detail on this, but we developed our distribution plan, our rollout plan, based on the provincial rollout plan, and tried to stick as close as possible to it in terms of timelines. But we did have to make some changes locally to reflect the reality of the Pfizer supply reductions that all of Canada and Ontario experienced in January and February, and that were captured in that previous version of the Ontario placemat. And in addition, there were a few areas in the province which received vaccine earlier and in larger quantities than we did, because these were the areas that had the highest case rates when they planned the rollout provincially. And thus, our local timelines needed to be shifted somewhat further out to the right, so to speak, compared to the provincial placemat. That said, Waterloo Region started receiving vaccines earlier than a number of other areas of Ontario. And we have made excellent progress in distributing the vaccines that we have been given. And Dr. Ball will also touch upon that a little later on in terms of our numbers. So really, what I want to leave you with is our mandate is to ensure that every resident in Waterloo Region who wants a vaccine can get one. And now I'll pass it over to Dr. Ball.
Thanks, Dr. Wong. So maybe we'll move to the next slide. And that Perfect, thanks. So this is a visualization really of what Dr. Wong has already discussed in the placemat. It just shows the phases kind of in a linear fashion, phase 1, phase 2, and phase 3. And you can see under each the bullets in terms of the vulnerable populations, or the prioritized populations, I should say. So a couple of comments. Just on February 14th, we actually received from the province a direction with respect to the very next priority groups to immunize, and then the ones after that, following the completion of immunizations of residents of long-term care homes and high-risk retirement homes. So as soon as supply improves, we really know where our new first doses can be distributed to others besides these residents. And so the main difference is from what's already been communicated by Dr. Wong, an important one is when you look under phase 2, adults 80 years of age and older have been moved from phase 2 to phase 1. And that's something that I think has been lauded by medical officers of health and public health units and clinicians as a very good choice that's consistent with the data. And the very large grouping you see under phase 1, the second bullet point, healthcare employees, that was a very broad group. And so there was really a need for some direction and some subdivision of those groups for us to sort of understand how to sequence them. And that was provided. So now we have the healthcare employees divided into the highest risk, or the highest priority, I should say. And so that will often be those hospitalized workers who work on COVID units or the ICU, for example, along with the ones who serve long-term care home residents. So we have a subdivision to the highest and the very high group, and those groups will be done first. The very high healthcare workers will be those in settings such as primary care offices, including their staff, community specialists, pharmacies, midwifery, dentists as examples. And so we will be allocating vaccines to these highest and very high groups. And then we have the high and medium priority healthcare workers, which will be next and moved to phase 2 and done then. And so you can see, however, that staff and essential caregivers in long-term care and high-risk retirement homes, other congregate settings for seniors, our Indigenous adults, as well as adults receiving chronic home care, continue to be in phase 1. And this new direction will help with consistency of prioritization of groups across the province. Next slide. So this is a slide that shows our vaccine dashboard. And this is how we track progress and how we're doing in the region with respect to vaccine distribution. So this dashboard can be found on the Vaccine Task Force webpage and the Region of Waterloo website. And we are doing well in terms of distributing the supply that we've been given. You can see the numbers on the top left of the total doses administered, as well as, speaking to Dr. Gingrad's point about 2 vaccines required for the Pfizer vaccine, you can see the number of people who are totally vaccinated. So in terms of how we're doing distributing our supply, as of the end of the week of February 8th, if you look at our rate of immunization per 100,000 population, we have immunized at the rate of 3,839 doses per 100,000 population. And that's, that compares to the Ontario rate of immunization of 2,977 doses per 100,000 population. Next slide. So let's talk about how we're going to get to 10,000 doses per day and beyond. Next slide. Okay, so this is a slide on the 5 types of clinics. And this modality, this is a really good description of our approach across our community. So this is a community effort. As Dr. Gingrad discussed, Pfizer has some very particular properties, including the fact that it needs extremely cold temperatures. And many people have asked, Why is this rollout quite different? You know, we've had large scale immunization programs before, and they typically land in the community with primary care or with pharmacy or with public health. But again, the fact that we had such scarcity and such a special vaccine requiring this very low temperature is why we actually had our vaccine land in the hospital at Grand River Hospital. That's done a great job. And so that actually dictated as well, when we were given our very first priority group of long-term care home residents, staff, and essential caregivers, we had to really think through. At that time, we were not able to move Pfizer. And so we had to vaccinate, of course, our staff, because we weren't able to bring residents out in the winter one by one into Grand River Hospital. And we were able to also vaccinate our high-risk hospital staff. But once we got permission in early mid-January to move Pfizer, then of course that changed things significantly. And that's our second clinic type, the mobile clinics. So those are best thought of when you cannot bring a person to the vaccine, but you need the vaccine to come to the person. And so, of course, we were able to mobilize under the leadership of public health, interdisciplinary teams with folks from the hospital, primary care, the region, to really get these teams going, and they will include pharmacists soon, to really get these teams going and to go and vaccinate the residents of long-term care homes and prioritized retirement homes. And mobile actually has the opportunity as well to create clinics, pop-up clinics in sites that are appropriate. And that can be other congregate settings for seniors, other populations that are disproportionately affected by COVID and maybe experience barriers to access in the public mass immunization clinics, as an example. We've been working with our urban Indigenous community that's been providing tremendous leadership in terms of where a culturally safe and appropriate space would be and how that vaccine would look like. And really that's another example of leaning in with mobile clinics. And another example actually would be those who are marginalized with insecure housing, and really working with shelter workers and outreach workers who know the population to think through the best way of a mobile clinic. The three remaining modalities are also important. So the large public health mass immunization sites are going to be our big engines, and they're going to provide the high volumes that we're going to need to get to 10,000 a day. And those are also going to be interdisciplinary. There's going to be 2 sites, and they're going to have staff from the region, from the hospital, primary care, community specialists, pharmacists, and many others. And the next modality is described as mid-sized clinics or fixed primary care sites. And these will be distributed team-based sites at family health teams or CHCs, including those that serve our rural population. And lastly, we will have our smaller sites. So once we have enough vaccine that is fridge stable and plentiful, this will look much more like the normal community vaccines where we have them in primary care and pharmacy. Next slide. Thanks. So this slide is actually quite helpful as well, because it kind of shows some of the level of planning. As we look at those 5 different clinic types, you can see that we have our initial ramp up period where we study and we learn, and then we have a maximum target. And all of those maximums, they do actually end up being over 10,000 doses per day. You can see as well that they will roll out at different times. Next slide. And this is a really wonderful infographic by the region, and it actually communicates a few things. So if you look at the horizontal stripes, phase 1, phase 2, phase 3, and you look at the legend on the bottom, you'll notice a few things. First of all, we have the hospital clinics up at the top left corner, and that makes sense with what I've told you about why we had our initial start at the Grand River Hospital, which will continue being a modality for some time. And then you can see at the very bottom right, we have some different icons. And those are our mass immunization clinics, primary care, and pharmacy. So over time, as those vaccines get more plentiful, and we have more fridge stable vaccine, this really does become a community rollout, landing where we often will see vaccines land. Another way of looking at this infographic is looking at the population types at the top. So one point that might be helpful to know is that sometimes, and this is important to us, choice is very important, and sometimes a population may be served by more than one modality. So in addition to them running at the same time, they may serve the same population. An example might be adult chronic home care, where some of those people will certainly be able, with some support, possibly to get to a primary care site or a pharmacy, while others are quite immobile and would need, particularly when we have more fridge stable, transportable vaccine, they may actually benefit from having, for example, a mobile approach. Our Indigenous community partners certainly have raised the idea as well of, in addition to mobile teams, possibly some community members preferring primary care as a site, as many others have. So this is an example, I think, of the layered approach that we have tried in the region to have that will give our citizens, I think, the most choice and the most option. Thank you. That's my last slide.
Thank you, Dr. Wong and Dr. Ball, for providing the information. So we've now heard some information about the vaccine itself, and we've gotten some details about the vaccine rollout and distribution in Waterloo Region. So now I'm going to introduce Julie Kaplash, who is the communications lead for the Vaccine Distribution Task Force, and Julie will show us our communication options and a newly developed communications toolkit that can be something that everyone that's joined on this webinar tonight as community leaders and organizations can really utilize to help get some of the information that we talked about today out to others in the community. So I'm going to welcome Julie on to the stage.
Thanks, Fazia. We can go to the next slide. So I first thought that it would be important for us to talk a little bit about what our communication goals are for vaccine communication. And you know, besides the obvious goal of wanting people to get vaccinated, we also really wanted to establish a relationship quickly with the community and be the trusted source for information about vaccines. We also knew that we had to communicate broadly. There's a lot of people who are interested in vaccine and a lot of different audiences. So we wanted to use a variety of tools and really be out there communicating the message on a variety of platforms. We also wanted to dispel information and provide information where there might be gaps and direct people to our website where reliable sources can be obtained. You can go to the next slide. So in terms of resources, we had to start somewhere. And so in December, we really started working on establishing some of the foundational resources that you have probably seen and become familiar with. As we're building out more resources and targeted resources that will be available to help various communities. So we have our standard website with FAQs, materials, and information, as well as our social media and media cycles. We participate in a weekly media briefing every Friday at 11:30. It's streamed live on the region's YouTube channel, and we're there every week to provide an update on where things are at with vaccine rollout in the community. I also very quickly wanted to connect with Fazia and the community engagement and outreach team, at first just to understand what the needs are, and also to just make sure we have a strong connection so that when there are specific needs that we can support through communications, that we're there to do that. We did develop a toolkit for community partners. We know there are a lot of people out there who are connected to various communities and really want to help us in sharing the messages. And so we wanted to put something together and get that out there quickly so that people could start to spread the word and help us out. We also recognize that not everyone is on social media or the web. And so I've also been making a connection with our Service First call center to ensure that for anyone who wants to call us to get information or talk to someone on the phone, that our call center agents have the same important information and up-to-date information that they can share with the public. Next slide, please. So in terms of the main COVID-19 vaccine information page, this includes a lot of general information about the vaccine itself. It also includes information about the rollout, and we do continue to update it quite regularly. You can also find more information about the task force, updates and news, FAQs, and translation tool, as well as translated resources. And everything that you'll find on the website, it's something that you should continue to go back to because we are updating it and improving it on a daily basis. Next slide, please. So I wanted to drill down a little bit more on the main page for our COVID-19 vaccine information page. So I've highlighted a couple of key spots on the page. You'll see the red circle at the top, and that's where you can access our translation tool. And I'm going to talk a little bit more about that in a minute. But then at the bottom where those blue boxes are, where the arrow is where you'll find the blue boxes are actually shortcuts to the more popular information on our website that we know a lot of people are looking for and want to get to quickly. And again, we add to those buttons and we'll even change them as the information evolves. You can move slide. So let's talk a little bit more about translation. So all of our web pages on the Region of Waterloo's website have the translate option at the top. And so what you can do is you can click on that plus sign at the menu and at the top, and the menu will drop down, and there's over 90 different languages to choose from. So when you choose a language on whichever page you're on, the text on the page will update to the particular language that you're interested in having the translation in. You can move slide. So in terms of translation, the feature doesn't work with PDFs. So as much as we like PDFs, and we certainly do create them for certain communications needs, we also know that in some cases, when it comes to translation, we want to make sure we're also embedding the important information into our website. So with the PDFs, we have started to create plain text PDFs on our website as well. So even in the information within the toolkit that we're going to talk about next, you're still able to translate those documents into other languages in order to better communicate with your audiences or for your own personal preferences. Next slide, please. So we're also monitoring closely other reliable sources like Health Canada as they are creating PDFs and resources in other languages. And so we want to make sure that we're curating those and bringing those to one place so they're easy to find. So when you visit our vaccine information page, there is a section for all the translated resources that we've been able to find, and they're laid out for you there, and you can access them. Next page, please. So, of course, like I said before, not everyone is using the website. And so I wanted to highlight that translation is also available 24/7 through our Service First call center. And our call center agents actually have access to translation in over 200 different languages. And there's also a line for people who are deaf or hard of hearing. And when you're speaking with someone in the call center, you can also request alternate formats if there's something that you want in a different format. Next slide, please. So I'll talk a little bit about the toolkit now, and that's the link at the bottom if you're interested in checking it out and seeing what's there. But basically, we had a lot of keen people in the community who wanted to help us out with communicating messages. So we've created this toolkit, and it's something that we will continue to add to. But basically, it's there for anyone to access. You can print posters, you can print fact sheets, you can access social media assets, and help us share messages about the vaccine and information about the vaccine. Next slide, please. So this is just an example of the fact sheet that is available. And again, you can download this fact sheet, you can print it, you can send it through email or social media. We've tried to prepare all the resources in our toolkit to be in plain language so that they're easy for everyone to understand. And again, we're going to continue to add resources to the toolkit so that they're useful throughout the rollout. Next slide, please. And so this is just another example of a poster that's available in the toolkit. Next slide, please. For those of you who use social media, we would welcome you to follow us on Twitter, Facebook, Instagram. We are doing regular updates on those channels, so the handles are there. If you're still inclined to use a hashtag, please join us with our Team Vaccine WR hashtag. And again, for anyone who's interested in getting those updates from YouTube, Fridays at 11:30, it's a great opportunity to get a update on what the region is up to in terms of COVID response, but also hear a vaccine rollout update. Next slide, please. So the last thing that I wanted to leave you with is something that we're very aware of, is that there are a lot of people who are worried right now that they won't hear when it's their turn. And something that you can help us out with today is provide some reassurance in the community that whenever we move to a new group being eligible to be vaccinated, we plan to communicate that broadly and through a multitude of different channels. So not just web or social media, but through, potentially traditional media, radio, TV, through professional groups, through community partners, and even through primary care and pharmacists. We are as concerned about making sure everyone gets their turn as you are, and I can assure you that the plan will be to communicate broadly. And I really do want to say I appreciate anyone who is also interested in helping us and using the toolkit and doing the same. It really goes a long way to helping, and I want to say thank you. And that's it for me, so I'll turn it back over to you, Fazia.
Thanks, Julie. Thanks for all of that. We can end the slideshow presentation.